Hi, my name is Pamela Coons, Associate Professor of Medicine in the Division of Oncology at Yale School of Medicine and Yale Cancer Center. I'm excited to announce ASCO's new open access journal, JCO Oncology Advances. As the inaugural editor-in-chief, I hope to support JCO Oncology Advances to become the premier platform to bridge the gap between accessible scientific research and clinical care. Stay tuned for more information, including new article types, at ascopubs.org/JCO Oncology Advances. We look forward to seeing your submissions in spring of 2024.
This JCO podcast provides observations and commentary on the JCO article, Interim Cosmetic and Toxicity Results from RAPID, a randomized trial of accelerated partial breast irradiation using 3D conformal external beam radiation therapy by Olivotto and colleagues. My name is Reshma Jagsi, and I am an associate professor at the University of Michigan Medical School in Ann Arbor, Michigan. My oncologic specialty is radiation oncology. Radiation therapy is a critical element of breast-conserving therapy that yields substantial improvement in local control and a modest improvement in survival. In most studies of adjuvant radiotherapy, standard fractionation with doses of 1.8 to 2 gray per treatment has been administered to the whole breast once daily. This approach relies upon the radiobiologic rationale that slowly dividing cells of normal tissues can repair radiation-induced damage between small daily fractions in a way that rapidly dividing tumor cells, often characterized by deficiencies in DNA repair, cannot. Thus, fractionation of dose contributes to the therapeutic ratio of radiation treatment. Because 5 to 6 weeks of standardly fractionated treatment are necessary to reach total doses that generally control microscopic disease, concerns have arisen regarding the convenience, access, and cost of this approach. At the same time, evidence has emerged to suggest that breast cancer cells may be more sensitive to larger fraction sizes than previously appreciated, suggesting that lower total doses of radiotherapy may be equally efficacious if treatment is administered in larger daily fractions. Therefore, interest in hypofractionated schedules of breast irradiation has grown. Several studies have explored a variety of schedules for hypofractionated whole breast irradiation. Others, inspired by findings that suggest that the majority of local recurrences after breast-conserving surgery occur in the region of the tumor bed, have been motivated to explore treatment to only part of the breast. These studies postulate that even more radically hypofractionated and accelerated schedules of treatment, commonly referred to as accelerated partial breast irradiation, might be tolerable due to the reduction in the volume of tissue irradiated. The earliest studies of partial breast irradiation utilized brachytherapy, but in more recent years, interest in administering partial breast irradiation via conformal external beam irradiation has grown as a result of improvements in targeting and dosimetric planning. External beam treatment is non-invasive, allows treatment after full pathologic information is available without subjecting the patient to a second surgical procedure, and may be less operator-dependent compared to brachytherapy options. A dose of 3.85 gray delivered twice daily over 5 days was adopted for external beam partial breast irradiation on the NSABP RTOG trial and was also the schedule tested in the RAPID trial reported by Olivotto and colleagues. Several reports from single institutions have, since initiation of these large national randomized trials, raised concerns about the possibility that this approach might be suboptimal. External beam techniques require a significantly higher integral dose to the normal breast, and single-arm trials at Tufts and the University of Michigan have suggested that rates of adverse cosmetic outcomes might be more substantial than usually observed with standard whole breast irradiation. However, given the small sample sizes and other limitations of these studies, as well as the fact that similar trials at other institutions have demonstrated excellent cosmetic outcomes, the community has been left to wait the analyses of large, well-designed, randomized trials to clarify this important issue. In the article that is the subject of this podcast, Olivotto and colleagues present the results of the interim toxicity cosmesis analysis in their large Canadian randomized trial comparing external beam partial breast irradiation to whole breast irradiation. Strengths of their study include its multi-center randomized design, careful quality assurance, and triangulation of evidence from multiple sources. Specifically, subjects were evaluated by trained nurse observers, provided their own perspectives on patient-recorded outcomes questionnaires, and contributed photographs that underwent blinded physician review for cosmetic outcomes. Adverse cosmesis was more common in patients treated with partial breast irradiation, as assessed by the nurses, the patients themselves, and blinded physician reviewers of photographs. The substantial, consistent, and significant differences observed using data from multiple sources are both persuasive and clinically relevant. Particularly interesting was the finding that cosmesis was stable or improved over time in a higher proportion of whole breast irradiation patients as acute hematomas and edema resolved, and cosmesis deteriorated over time in a larger proportion of partial breast irradiation patients. Of note, the findings of this Canadian RAPID trial diverge from preliminary findings obtained to date from an interim analysis of the large and similarly well-designed randomized trial of partial breast irradiation in the United States, RTOG 0413 NSABP B39. Interim analysis of the subset of patients treated with external beam partial breast irradiation on that study did not reveal significant increases in severe toxicity as evaluated by treating providers on routine case report forms using the common toxicity criteria for adverse events. However, the RAPID trial suggests that adverse cosmesis may not adequately be captured by CTCAE scoring. Indeed, they found very low rates of severe CTCAE-graded toxicity, even in the context of substantial rates of adverse cosmesis. Of note, the NSABP RTOG trial was carefully designed also to collect the results of global physician cosmetic assessments, patient-reported outcomes, and review of photographs. We eagerly anticipate review of these other important endpoints in this important trial. It is, of course, possible that even with further review, the outcomes in the RTOG NSABP trial will differ from those in the RAPID trial. Subtle differences in the limits on dose prescription, including definition of the normal breast volume, may affect the development of toxicity in this setting, as may variation in how much the treating providers approach the allowable limits with their treatment plans. As Olivotto and colleagues note, although there was an excess of adverse cosmetic outcomes on their trial, many patients treated with partial breast irradiation had good or excellent outcomes. Additional dosimetric studies of the data from both trials would be particularly valuable to illuminate which patients are most likely to experience adverse cosmetic outcomes, information that could then be used to further refine dosimetric parameters for this approach. Of note, these findings should not be extrapolated to the expected outcomes of brachytherapy-based approaches for partial breast irradiation. Given the steep dose fall-off with brachytherapy, smaller volumes of normal breast are exposed to large doses per fraction of radiation. Other studies have considered outcomes of brachytherapy-based techniques, including a highly publicized observational study of Medicare data published last year. In that study, patients undergoing brachytherapy-based partial breast irradiation had a higher mastectomy rate than those who received whole breast irradiation. However, that study was a retrospective observational analysis, subject to the usual caveats that association might not imply causation. Moreover, the study was situated in an era of relatively early experience with brachytherapy, before criteria for appropriate patient selection and risk factors for complication had been articulated. So its results may not reflect the toxicity or efficacy of brachytherapy as applied now that experience with this approach is more mature. Therefore, the findings of the RTOG 0413 NSABP B39 trial, which allowed both brachytherapy and external beam approaches for partial breast irradiation, will be valuable in the further evaluation of concerns raised to date about both techniques. In summary, partial breast irradiation is a strategy that may make radiation treatment more accessible and convenient for some patients, and it is therefore a worthy subject of ongoing investigation. However, as with any new treatment approach, carefully designed trials are essential to establish appropriate dose, volume, and scheduling parameters. The interim toxicity results reported in this issue from the experience with external beam partial breast irradiation in the Canadian RAPID trial provide compelling evidence that current schedules for partial breast irradiation approach the steep aspect of the toxicity curve and merit caution before application outside the context of a clinical trial. Therefore, we firmly believe that patients who wish to be treated with partial breast irradiation should be enrolled on prospective trials. Those patients who wish to pursue partial breast irradiation outside the context of ongoing protocols should be fully informed of the results of the Canadian trial, as well as the generally nascent and evolving nature of our knowledge regarding this approach. Only with the ongoing support and follow-up of large, carefully designed trials like the Canadian RAPID trial and the NSABP B39 RTOG 0413 can the risks and benefits of various approaches to adjuvant breast irradiation ultimately be defined and appropriately refined. This concludes this JCO podcast. Thank you for listening.
For more original research, editorials, and review articles, please visit us online at jco.org. This production is copyrighted to the American Society of Clinical Oncology. Thank you for listening.